Good morning. To summarize my entire talk, what he said. Let's get into maybe a few more details, however. Let me see if I can share my screen here. There, I hope we've got it. And the important part about this is, of course, that it's been 2 decades since I started doing this based on some research out of the University of Washington many years ago. We've come quite a ways from Dr. Hay in 1931. The greatest danger to a person with high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. As a matter of fact, we are reducing it. And we'll discuss a little bit later, perhaps the impact of elevated blood pressure and stage 1 hypertension on pregnancy, and using impedance cardiography to treat it. I was actually at the SMFM meeting when Dr. Tom Easterling presented this as a fellows research in 1990, which gives you some indication of how long managing hemodynamic subsets has been around. And this slide shows that there was a hemodynamic subset, hyperdynamic patients specifically, with an elevated cardiac output, who were destined to go on to develop preeclampsia. Being a good scientist, that group at the University of Washington then randomized 60 patients to either get 100 milligrams of atenolol. All 60 of these were hyperdynamic by measurement, randomized to get a beta blocker versus none. And what we see is a marked reduction in the incidence of gestational hypertension and toxemia. Now, this study was done well before our more recent appreciation of the fact that gestational hypertension and preeclampsia or toxemia are probably the same disorder, just on a spectrum. Just to show that this is not a Johnny-come-lately and has been confirmed by multiple other ultrasounds, what we see here in this graph is showing that the elevated cardiac output can be associated with the ultimate development of preeclampsia. If you have preeclampsia with growth restriction, then you're in a different hemodynamic subset where the total peripheral resistance is increased and perhaps needs a different therapeutic modality. So the protocol that we've been using for the last 20 years, and the data that I'm going to show you, is all done with the NICAS measurement of impedance cardiography, hemodynamic measurements. Monthly hemodynamic evaluation. This is done with the patients seated. We run the measurement and treat their hyperdynamic patients with beta blockers and vasoconstricted patients with vasodilators. Oftentimes they need a beta blocker to control the heart rate. Now, unfortunately, there we go. I knew I'd missed a slide. Sorry about that. If we were just taking it at face value, this slide shows everything that we need to know. This is the initial hemodynamic evaluation on close to 1,000 patients who were treated over a decade. And basically, it shows that the hemodynamics are quite varied. The green line is just showing the mean arterial pressure associated with 140/90. And what we see that is that at any given blood pressure by mean arterial pressure, we have patients that are severely vasoconstricted, we have patients that are hyperdynamic, and we have some patients that are mixed. Echoing what Dr. Romer said, there's nothing that's going to predict. Size of the patient doesn't predict, diabetic status doesn't predict, history doesn't predict which hemodynamic subset you're going to belong to. You do notice in the red triangles here, with very elevated blood pressures greater than 160/110, they're almost all mostly vasoconstricted. So since we can't guess what their hemodynamics are going to be, we measure, and then, like I said, appropriately treat, and we'll take a look at the outcomes. And I'm using a standard study that has had several reevaluations, looking at the outcomes in the calcium channel. The calcium replacement trial listed there. And what we see is preterm delivery is very similar between the two studies, which had very similar numbers of patients, fairly steady in the 30% range, rising somewhat with increasing hypertension. However, very importantly, we have taken growth restriction out of the mix. If you're vasoconstricted, you should have vasodilators. If you're hyperdynamic, you should have beta blockers. And what we see, the result of that kind of a measurement and then subsequent treatment, is that the growth restriction rate is all about the same, between 8 and 10%, markedly different from unselected antihypertensive treatments as represented by the maternal fetal medicine unit study shown there. Also very satisfying to us, and I can't completely ascribe this to antihypertensive treatment, because part of the entire protocol is attention to following fetal growth and antepartum fetal testing. However, across blood pressure subsets, what you see is the stillbirth rate in our patients is about 2%, which is half that, and is not, associated with increased levels of hypertension, which is really quite remarkable. I wanted to show a more recent study. This was the study of treating all patients with labetalol, attempting to get very tight control versus being satisfied with less tight control. Since there was no difference between the two groups, I grouped them together. And so notice that each one of these studies has approximately 800 to 900 patients. And what we see is, when you pay attention to the hemodynamics in your antihypertensive selection, you have improvement in growth restriction, as well as in the rate of stillbirth. So now you have a choice. Now that you know this, you can't unsee it. You can do what's currently recommended, which is basically choose your own favorite drug, regardless of what their hemodynamics might be. The less tight versus more tight control didn't show any improvement, but the most effective is treatment being guided by non-invasive hemodynamics. There are, of course, some things left to explore. We have not done any targeted evaluations of which medications are best. There are different beta blockers that tend to work better. Are there different vasodilators that might work better? There's more and more interest being paid to more subtle signs of hypertension, the elevated hypertension in stage 1, and all studies that I've noticed to date suggest that there is a fairly linear relationship between degree of hypertension above 120/80 and perinatal outcome. Looking as to whether diabetes, twins, and obesity have an effect. And what we're really interested in, and now that we've been doing this for 20 years, or we'll be attempting to look at, is, are there lifetime outcome differences from this treatment? Basic science is, where do these differences start off? Are there differences in the placental pathology? And one thing that we're attempting to get off the ground is there a difference in the growth factors in these hemodynamic subsets? Thank you.